Medurstand Understanding Medicine.
Professor Aziz Rehman from Medurstand-Understanding Medicine. In the series of diseases on kidneys, we are dealing with chronic kidney disease, and in my earlier presentations, I have covered the pathophysiology, diagnosis, and the complication, the treatment, and I have also covered renal replacement therapy. And I think this is extremely important component of this disease, the dietary management at the advanced kidney disease. I think kidney disease, advanced kidney disease, is one of those diseases where dietary management is of utmost importance because we eat such a variety of foods. Many of them they put load on the kidney. Some substances are retained if the kidneys are not functioning properly, so they can come, and they come from diet, so we can avoid them by sensible eating. And there are certain things which are tend to be low in body because of kidney disease, and we can supplement them in our diet. So diet makes, I think, an extremely important component of management of chronic kidney disease. And I believe a professional dietitian or nephrologist will help. And it is also important that the diet would vary from person to person, depending upon the extent of kidney disease and also depending upon your biochemistry. For two patients with same level of GFR, with different potassium level, different calcium level, different sodium level, the diet could vary. So I think you need to keep a constant touch with your dietitian or a qualified physician or nephrologist to keep your diet balanced in a way that you receive all the essential macronutrients, micronutrients, vitamin supplements, and you don't get excess of those which are difficult for kidneys to handle. So with this started, I'm going to start the presentation. The overall advanced CKD, which is typically defined as stage 4 and 5, requires significant dietary modification to manage symptoms and also to slow down disease progression. Now, this is important because we are always trying to do something to slow down further disease progression. Now, stage 5 is already an advanced disease and patient may be already on dialysis, but still if some kidney functions are preserved, that will help to improve quality of life. So what are the goals? I'm going to list the first 6 goals of dietary management, and then I will discuss the main component of this. First of all, I think manage fluid retention. Fluid excretion is the main job of our kidneys, and kidneys are so sensible. Kidney knows how much water to retain and how much to excrete. Our intake of water could vary from like 2 liters to maybe up 7, 8, 10 liters, and still our kidneys manages to maintain our status of hydration in a very, very narrow range. So if there is a kidney disease, there is a possibility of water retention, so you have to avoid extra water. And then control blood pressure. Blood pressure could be responsible for CKD, and CKD would further cause hypertension, and hypertension can lead to non-kidney complication like stroke or heart attack or pulmonary edema. So I think we need to manage food in a way that helps to control blood pressure. And then reduce proteinuria. Proteinuria is definitely a pathological feature, and we know that proteinuria further leads to nephron damage. So we would like to control diet to control or to reduce proteinuria. Then maintain electrolyte balance. All important electrolytes, sodium, potassium, chloride, bicarb, phosphate, sulfates, urates, all are managed by the kidneys. So if there is kidney disease, there is a possibility of accumulation or in some cases deficiency of these electrolytes. So again, very important consideration that we maintain their electrolytes. You know, electrolytes are extremely important for nerve function, for muscle function, for cardiac function, for intestinal function. So I think we need to maintain them in a narrow and the physiological range to maintain their all body functions. Then prevent malnutrition. Many patients with chronic kidney disease are anorexic, maybe be having nausea, some may be having vomiting. We just can't tell them to restrict, to not eat food, to reduce their food intake. We have to manage their food in a way that provides essential amino acids, essential fatty acids, and all essential ingredients in the form of vitamins and minerals, and we have to provide them enough calories from a source which does not produce extra urea or creatinine. Then manage uremic symptom. Many patients, they have many symptoms, so those symptoms are related to calcium and potassium and other things. So I think managing their symptoms is also an important consideration. So these are 6 important considerations why diet is extremely important in patients with chronic kidney disease. So first of all, let's talk about macronutrient guidelines. Water comes, I think, first of all, normally we take water in unrestricted quantity because we are assured that our kidney is capable of removing all extra water. Our body needs 2 liters, 2.5, 3 liters max daily, but extra if we take in the form of beverages, in the form of tea, coffee, any other drink, and that is removed by the body. But this function is compromised in kidney disease, chronic kidney disease, and that effect would be variable. Some people with chronic kidney disease have more tendency to retain water, others have less tendency to retain water. Some may have just normal water excretion also. So in fact, in some cases, there could be actually extra water excretion also. So accordingly, you will manage fluid intake. So typically, it is restricted to 1 to 1.5 liter a day. Now note down, this is not just the water which we drink, it would also include all the liquids like in tea and in coffee and also in fruit and also in the salan we take. So that fluid will have to be counted. You will have to make some estimate how much fluid we take in all these forms collectively. And the sources, all beverages are, I think we consider beverages as primarily water, but some beverages may have added potassium, so beware. Then soups, may also have added potassium. I think not added potassium, but since soup is actually like a broth, there may be some intracellular potassium. So you can take beverages and soups, but water, I think water is best. The water in the form of fruits and vegetables should also be included. So you can consider the total amount of water taken from all sources. What is the rationale? It helps prevent fluid overload. People with CKD are prone to develop fluid overload. One, kidneys had difficulty excreting. 2, because of associated hypoproteinemia, people have tendency of water going into the third space. So that is why we have to restrict water intake, and it would prevent complications like hypertension and edema, generalized edema, pedal edema, scrotal edema, but most importantly pulmonary edema. So restricting water will prevent all these major complications. Of course, you would sometime will have to make adjustment according to one's daily losses, because losses of water varies. If somebody works in the sun and sweating, that person would require some extra water to compensate for that additional loss. Somebody having vomiting or diarrhea, I think that again some adjustment will have to be made for that condition. So that is why I say you have to keep a contact with your dietitian and the nephrologist to make daily adjustment. Now, next macro nutrient is protein. Protein is very essential. Protein is the main component of our muscle. So we need muscle. People with CKD, they tend to develop sarcopenia, the muscle loss. So we have to provide them a certain amount of protein, which is like 0.6 to 8 grams per kilogram of body weight. Now you can easily calculate if somebody is 100 kg, he would require 80 grams, and if some and or 80 grams or from 60 to 80 grams. Somebody who is 100 kg. In a normal person, it is recommended to take above 1 gram, 1 to 2 grams actually protein. And in this case, it should be restricted because extra protein can lead to excessive creatinine and other nitrogenous substances. Sources: high quality protein such as lean meat, poultry, fish, eggs, especially egg white, dairy, and plant-based proteins like bananas and tofu. Now, please note down, some diets may be beneficial from one perspective and may be harmful from the other perspective. Now, dairy, for example, has got good quality protein, but it would also be having some phosphate. So when we talk about phosphate, I will tell you that dairy products should be avoided. So I think you need to make a balance. If somebody has high phosphate, maybe you should drop dairy from here. Similarly, these proteins, they are very good, and the plant protein, originally it was thought that the proteins coming from animal source like this meat, poultry and fish, they are high biological value protein, meaning that they have essential amino acid which our body needs. But now we know that some plant proteins are also very rich in essential amino acid. Like tofu is made from soybean, and that has all 9 essential amino acids. And plant-based proteins may be easy to digest for these patients. So I think you need to try both and see which one works better in your patient. Then rationale. What is the rationale? Rationale is to reduce workload on the kidneys. Extra protein would put extra load of excretion of urea, nitrogen and creatinine, because all these come from protein. But we have to provide a bare minimum, otherwise patient would develop catabolism. You know, according to our body metabolism, a minimum of 30 grams of our flesh is catabolized every day, and that needs to be replaced because our body renews itself. So that 30 grams, minimum 30 grams, which is like half of this. So I think minimum 30 grams, but recommended is this in a person like 100 kg. This one I just mentioned, that needs to be replaced to prevent sarcopenia, right? Otherwise, muscle will be catabolized but will not be replaced, and people will develop sarcopenia, muscle loss, and that would of course will reduce their energy and would not look nice also. The next is carbohydrates. Carbohydrates are our staple diet, and we are normally consuming, I think, more than 60-70% of our diet is carbohydrates. In people with chronic kidney disease, carbohydrates may be a preferred source of nutrition. We don't want to give it too much, but about 60% of the total food can come from the calorie wise from the carbohydrates. Why? Because I'm going to just explain in the rationale, but carbohydrates are easily available in many foods like bread, like roti, like potatoes, like fruits, and they are the good source of nutrition for many people with CKD. And complex carbohydrates such as whole grains and fruits and vegetables are preferred over plain carbohydrates, because plain carbohydrates, they get absorbed very fast and they may lead to glucose surge. Rationale to provide primary energy source, like in all of us with even normal kidney function, our first level fuel is glucose, which comes from the carbohydrates, which is actually carbohydrate. So if patient gets enough carbohydrates, only then we can be ensured that the protein which this patient is taking, that will be used for muscle building and will not be catabolized to produce energy. Our second source of fuel is fats and proteins. So if you are not giving the person enough carbohydrates, but the person's protein which he is taking, that will be then used as a fuel. So patient will not build his muscle, but this will be like wasted. Okay, so that is why we have to provide enough carbohydrates, and especially in the form of complex carbohydrates. Now, another macronutrients are fats. Fats are very, very essential. Mostly people see fats in a negative sense, but we know they are very important. They have some very essential nutrients like essential fatty acids, and it's a very, very good and rich source of calories. So recommended intake 30 to 35% of total daily calories can come from fats. Now this is slightly more as compared to normal people. In normal people, we encourage protein as a second source. After carbohydrates, we promote proteins as the second source of nutrition. But in this case, I think after carbohydrates, fats should be the second source of nutrition, and because they are very rich in calories, but you need to take healthy fats, those fats which do not have too much cholesterol. One simple rule: fats coming from the plant source, they actually have much less cholesterol as compared to the same type of fats coming from the animal source. So monounsaturated and polyunsaturated fats found in all oils, particularly olive oils, avocados, nuts, seeds, and fatty fish. These are good fatty acids and good fats, and they should be consumed as the main source of diet. Rationale to prevent essential fatty acid deficiency, to provide essential fatty acids and calories. And just to remind you, what are essential fatty acids? Just like essential amino acids, these are the fatty acids which our body need, but our body cannot make from another fatty acids. They have to be consumed as such. Many other fatty acids can be made from other fatty acids in the body, but essential fatty acids are those which have to be consumed in diet, otherwise they will not be available to the body cannot make them. And they are very, very essential because nerves and neurons and cell membranes and all the stuff in the body, they have fat in it. So I think this was a brief account about the macronutrients, and now I'm going to talk about the micronutrients. There are guidelines about micronutrient. Now, what are those? What are the important micronutrients? First of all, sodium. Now, sodium is what we take in the form of salt. What we take in the form of salt is actually sodium chloride, approximately half. Like for example, if we take 8 grams, 4 gram would be sodium and 4 gram will be chloride. In chronic kidney disease, both have to be restricted. So we have to restrict sodium. You know, sodium is present in our diet naturally. For example, all natural fruits would have some sodium in it. If you take some fruit, if you take even steamed chicken or fish, that has some sodium in it. But we also add sodium in cooking, sodium chloride. And believe you me, all of us take sodium in excessive quantities. We're lucky that our kidneys are very efficient to remove extra sodium, but in patients with CKD, we have to risk sodium. I believe if you just completely stop added sodium in our food, that may be enough for people with CKD. So people with CKD, advanced CKD, should develop the habit, should develop their taste to to eat food and to enjoy food without added sodium chloride. Recommended intake should be less than 2.3 grams per day. Now this is the amount which would be present in the food naturally. So that means no added or maybe very small amount of added salt. Sources: avoid processed foods. These days we take a lot of processed food, and processed foods, they have a lot of sodium and soda bicarb. Canned foods also have sodium. Sodium is also used as preservative. And restaurant meals, all the restaurant meals, they put a lot of salt because they have to bring out the best taste. They're not caring about your heart or your blood pressure or your kidney. So I think you should avoid restaurant meals as much as you can. Of course, sometimes you will have to go to the restaurant for social reason, and think in that case try to consume as little food as you can manage. Take fresh herbs and spices and flavoring instead of salt. So that would aid flavoring to the normal natural food is a little bland. So adding these things will make it aromatic and little spicy. Rationale help control blood pressure and reduce fluid retention. Fluid retention can lead to pulmonary edema and pleural effusion and generalized edema. So I think unless you restrict sodium, you cannot restrict water, because if you continue to consume sodium, patient will feel thirsty. So you have to first control sodium, and then it will be possible to control water intake. So I think both need to be controlled simultaneously. Now potassium. Potassium is another very important salt. We consume it, and one point very important I like to mention here is that some people, they use sodium or salt substitute. Salt substitutes often have potassium in it. So if the CKD patient has to use a salt substitute, he has to make sure that the substitute does not have potassium, because potassium in his case may be actually more harmful than the sodium. So potassium has to be controlled. Recommended typically limited to 2 to 3 grams per day depending on blood levels. If somebody has hyperkalemia, then of course you will try to remove potassium from his diet completely. That may not be easy, because all foods coming from animal source, all meats, they have potassium, because potassium is primarily an intracellular ion. So all cells would have some potassium. It may not be possible to completely eliminate potassium from diet, but you would like to try to reduce as much as possible if somebody has hyperkalemia. Those who have normal potassium or lower normal potassium, they can enjoy some more liberty in taking potassium. Avoid bananas and oranges and potatoes and tomatoes and spinach. Now, if you remember, I recommended these as sources of carbohydrates, right? So if somebody has hyperkalemia, then you will follow this rule. Then carbohydrates can come from other source, But bananas, which are very rich in potassium, oranges, potatoes, tomatoes, and spinach, they all have high contents of potassium, so they need to be restricted or avoided completely in these patients. Whereas patient can take apples, berries, grapes, and cabbage. They have other carbohydrates, but they are poor in potassium. Rationale, patient with chronic kidney disease, depending upon the stage, they have tendency to develop hyperkalemia. And hyperkalemia is very dangerous. It builds up and may not cause any symptoms, but at a critical level, it may cause serious life-threatening ventricular tachycardia or fibrillation, and patient may die suddenly. So hyperkalemia needs to be prevented at all costs. So I think this is the reason why we need to control patient's diet to control his potassium level. Another micronutrient is calcium. And calcium, people with chronic kidney disease, they tend to develop hypocalcemia for more than one reason. The main reason is that the calcium is absorbed and retained in the body by vitamin D. And vitamin D, what we take in the form of diet or the one which is produced in our skin, is not active vitamin. It is to be activated by first liver and then kidneys. So in patient with chronic kidney disease, this activation process is slow, and people with chronic kidney disease are likely to have a deficiency of effective vitamin D. So because of vitamin D deficiency, they are likely to develop hypocalcemia and also hyperphosphatemia. So both are harmful. That is why we need to regulate their calcium intake. Recommended intake individualized based on serum calcium level. All people with CKD would not have hypocalcemia, so depending upon the calcium level, you would adjust the calcium intake. In fact, some cases of chronic kidney disease may have hypercalcemia also, because hypercalcemic states can cause chronic kidney disease. So I think accordingly you will manage calcium intake. Avoid dairy products. Reason, although the dairy products have calcium, but they mostly also have phosphate. Now in patient with chronic kidney disease, we have to supplement calcium but avoid phosphate, because these people are likely to develop hypocalcemia and hyperphosphatemia. Both are responsible for hyperparathyroidism. So the calcium coming from dairy products may not be great, but the one coming from leafy green vegetables and supplements, that is very good. I think I would prefer supplement, because we are exactly sure what amount of calcium is present in that supplement and if any phosphate is present or not. So I think I normally prefer supplement as a source of calcium for the patients with CKD. Rationale, to prevent hyperphosphatemia and to prevent hypocalcemia, basically to prevent further kidney disease, further bone disease, which I will show you in the next slide. Phosphorus. Normally in the nature, calcium and phosphorus are found together in bone, in animal source, and in dairy source. So here the problem is that we want to take calcium but we want to prevent phosphorus. So that is why we have to be very careful. So recommended dose is 0.8 to 1 gram per day. Phosphate is also released from within the body, and that is usually enough. In fact, our kidneys are always trying to remove the extra. So I believe if you do not take phosphate in diet at all, although that may not be possible, so the phosphate which is released within the body may be enough, but up to 1 gram is okay. Now sources, avoid dairy products because they have phosphate in it, nuts, seeds, legumes, processed food with phosphate additives. So these need to be avoided. Now, if you remember, nuts and seeds I recommended when I talked about essential fatty acids. So again, I would like to emphasize the diet would be managed according to the individual needs. So only a qualified dietitian would be able to do that, because most physicians would not have that much information that they can manage their diet on daily basis. And if required, take phosphate binders, because some phosphate will be consumed inevitably. No matter how careful you are in choosing your diet, some phosphate will be consumed, because many diets they have phosphate. So if somebody has hyperphosphatemia, then phosphate binders are used. Phosphate binders, they bind phosphate and then prevent its absorption. Calcium carbonate is one great phosphate binder, and if taken with meal, it can provide calcium which is required, and it will bind phosphate if that also will serve the purpose. So I think calcium carbonate would be a great supplement in these patients. Rationale: by preventing hyperphosphatemia, we prevent secondary hyperparathyroidism, and by preventing secondary hyperparathyroidism, we prevent progressive bone disease, and also we prevent atherosclerotic cardiovascular disease, because hyperphosphatemia also promotes atherosclerosis. So I think that makes a very good point why we have to restrict phosphate. So this, I think I'm coming to the end of micronutrients, but some vitamins and minerals are also important. Let's talk about them also. Uh, Normally, vitamins and minerals, most of the vitamins, they come from vegetable and fruits. Some come from the animal source also. And normally we consume both animal and vegetable source meals. So I think normally we take vitamins from both sides. Minerals, they come from fruits and vegetables, and also from the animal source. So I think in these patients we have to make sure that they get essential vitamins and minerals. Now, supplementation: calcidiol or calcitriol, these are active form of vitamin D, they can be given. And then B complex, they are available in simple preparation. They can be consumed one pill a day. I think that is good enough. And then iron. Although many people with chronic kidney disease, they have anemia because of erythropoietin deficiency, but once you replace erythropoietin, you have to make sure that they getting enough iron also. Only then there would be effective hemopoiesis. Rationale: helps prevent deficiencies and manage anemia, because people with kidney disease, they may be anorexic and they may be scared to eat everything, and I think they are likely to develop deficiency of these vitamins and minerals. So I think you need to supplement that. Dietary fiber. Fiber is a very essential component of our diet, and recommended 20 to 30 grams of fiber. Fiber is something which is cellulose, which our enzymes cannot digest. They provide bulk to the stool, they promote gut movement, and they give you a satiety also, and they do not have any calories. And very importantly, these fibers are important for our gut microbiota. Gut microbiota is extremely important for our body function. I have a separate lecture on that, but you need to consume 30 grams of fiber. Sources: whole grain has got good fiber, fruits have got fiber, vegetables have fiber, legumes have fiber, but legumes also have potassium. So I think if somebody has hyperkalemia, you would like to avoid this. Then psyllium husk, this isabgol, this is very important. I think you need to consume a certain amount. Rationale, it supports digestive health. With fiber, your gut movement becomes better and it provides satiety. After eating food, it gives you the feeling of fullness. Prevents glucose excursion, cholesterol excursions also, because many of these patients may be having diabetes, may have hyperlipidemia. So you don't want to make their glucose and hyperlipidemia worse by providing food. So with fiber, these will be uh, prevented. I think very, very important. Now, I have constructed a sample meal plan. This may not be applicable to all. I will expose this, but let you read through it by pausing this video if you are interested. Right? So I'm going to expose all of this one by one because I want to save time. So this is the breakfast: oatmeal made with water or low potassium milk alternative, topped with fresh berries and a small amount of honey, a slice of whole grain toast with a thin spread of avocado. Avocado is not available in our country, so I'm not sure what substitute we can use. Grilled chicken salad with mixed greens. Grilled chicken means no salts added. Cucumbers, bell peppers, and a vinaigrette, which is vinegar with soybean, some oils, dressing, and small apple or a handful of grapes. In dinner, you could take baked salmon. Salmon is also not widely available in our country. It is available, but not widely, with side quinoa. And this is a great source of uh, uh, proteins. This comes from vegetable made from soybean, but it has got all 9 essential amino acids. And steamed green beans, a serving of mixed fruit salad, low potassium option. And then in snacks, one can take carrot sticks with hummus, unsalted nuts or seed, or some small biscuit or something like that. So I think this is one example. Of course, it would not be possible to eat the same menu every day, and this menu may not be to everybody's taste. So based on the principles I discuss, you can make your own, or you can ask your dietitian to construct the one according to your taste. So consider other comorbidities. So far we were discussing diet in chronic kidney disease, but many of these patients might have comorbidities. And I just go through this list: hypertension, diabetes, heart failure, chronic liver disease, hyperuricemia, celiac disease. So accordingly, you make further modification in their diet plan. So in conclusion, ladies and gentlemen, managing advanced CKD through diet requires careful consideration of macronutrients, micronutrients, and fluids, and personalized dietary adjustment required on regular basis, maybe day-to-day basis. A regular follow-up with a nephrologist and dietitian is extremely crucial unless you have developed skill yourself. Now these days many resources are available online. You can use those resources and maybe you can build up your diet plan yourself using those resources. This can help reduce complication and improve the quality of life for individuals with advanced CKD. Thank you very much, ladies and gentlemen, for watching this video. This has been Professor Aziz Rehman from Medurstand, and I look forward to see you in my next video.